Now we are going to discuss the clinical aspects of thrombocytosis. What is thrombocytosis? If the platelet count is more than 450,000 per microliter, this is thrombocytosis. There are multiple reasons for thrombocytosis. The most important is clonal thrombocytosis, that is clonal expansion, a malignant disorder. This is associated in many conditions. Essential thrombocythemia is the main. Then you can have this in polycythemia vera, in primary myelofibrosis, myelodysplasia with deletion at the 5q chromosome, the chronic myeloid leukemia, chronic myelomonocytic leukemia, atypical type of chronic myeloid leukemia, myelodysplastic syndrome, myeloproliferative neoplasms, Point syndrome, and familial thrombocytosis. These are clonal expansions. And then you can have reactive thrombocytosis, which can be seen in infections, inflammatory conditions, tissue damage, hyposplenism, postoperative, iron deficiency anemia, malignancy, rebound following myelosuppression with chemotherapeutic agents. And then you can have a spurious polycythemia. It's actually fault by the reading machine that finds many objects in the blood which appear similar to thrombocytes and included in the thrombocyte count. For example, microspherocytes, cryoglobulin, neoplastic cell fragments, schistocytes, and bacteria. They all are counted by the machine as platelets. This is an uncommon condition. Then what are the clinical features of thrombocytosis? Two main important features are thrombosis and bleeding. Then you can have some vasomotor symptoms. The thrombosis in reactive thrombocytosis is uncommon. It's 1.6%. It increases in reactive thrombocytes in the presence of other risk factors. For example, patients who got cardiac surgery, they may have an additional risk. So in itself, the reactive thrombocytosis does not produce thrombosis. A large series shows that there is only 1.6% risk of developing thrombosis, and that even with very high platelet counts. Risk is high in essential thrombocytosis and polycythemia vera for both microvascular and macrovascular thrombosis. Increasing age, prior history of thrombosis, and high leukocyte count enhance the risk of thrombosis. And then patient may have vasomotor symptoms which are not due to thrombosis. Classical example is erythromelalgia. And then patient can have bleeding. The bleeding can be because of decreased platelet functioning and acquired von Willebrand disease. The large number of platelets that takes up the von Willebrand factor and produces acquired von Willebrand type of disease that can result in bleeding. And then features of diseases which are causing a reactive thrombocytosis may also be present. For example, fever, weight loss, or a family history of thrombocytosis. So look for the presence of these features. Then get CBC and blood smear, JAK2 mutation. Look for the markers of inflammation which can cause thrombocytosis. ANA, ESR, CRP, ferritin as acute phase reactants. Platelets are acute phase reactions, so they can increase. So look for the evidence of acute phase reaction, and then bone marrow examination and abdominal ultrasound, CT, or chest X-ray to see other diseases which can cause thrombocytosis. Treatment. No treatment is required for reactive thrombocytosis. Even with very large number of platelets, generally require no treatment. No antiplatelet therapy is recommended. If bleeding and or thrombosis is present, look for an underlying cause of this. May be a clonal expansion rather than reactive thrombocytosis. Now, if the platelet count is more than 450,000 per microliter, see it is spurious thrombocytosis. Rule out spurious thrombocytosis. Then go for peripheral blood smear, acute phase reactants, and iron studies. If there is iron deficiency, repeat count on normalization of iron stores, and then acute phase reactants. If the acute phase reactants are present, this is reactive thrombocytosis. Repeat count on resolution of inflammatory process to confirm normalization. And if these two are not present, reconfirm the persistence of thrombocytosis. If it is there, go for evaluation of clonal thrombocytosis. For this, we get JAK2 mutation, V617F, BCR-ABL gene, and erythropoietin levels. If the BCR-ABL gene is positive, this is chronic myeloid leukemia. If the patient has JAK2 V616F mutation positive, BCR-ABL is negative with low erythropoietin, this is polycythemia vera. Then if the JAK2 mutation is plus minus, there is negative exon 12 mutation, BCR-ABL is negative and erythropoietin is high, then go for bone marrow biopsy. Consider MPL-TET mutations. They may be present. When you do a bone marrow biopsy, if the bone marrow biopsy is consistent with polycythemia vera, this is polycythemia vera. Especially if JAK2 exon 12 mutation is positive, so this is polycythemia vera. And if the bone marrow is consistent with primary myelofibrosis, this is myelofibrosis. And then if the bone marrow is not consistent with the primary myelofibrosis or polycythemia vera, consider erythrocytosis, myeloproliferative neoplasm, and myelodysplastic syndrome, and 5q syndrome. So these are the possibilities if the bone marrow biopsy is not consistent with polycythemia vera or primary myelofibrosis. Now, how would you treat the patient who has got clonal expansion of platelets? Individualize the risk factors. Patient has low risk, that is age is less than 60, no prior thrombosis, and if the patient has vasomotor symptom, put on low dose aspirin. Then go for secondary risk assessment, leukocyte count, JAK2 mutation status, and other vascular risk factors. If they're present, patient should be put on low dose aspirin based on individual risk profile. And then if there is high risk, the age is greater than 60, prior thrombosis, count is more than 1500 per microliter, cytoreduction therapy with hydroxyurea, the target to keep the platelet count around 400, and patient should be on low dose aspirin. If the patient is intolerant or refractory, then relax the goal to 600 platelets. Anaglyride may be tried in patients who are pregnant. Interferon alpha may be started, or otherwise radioactive phosphorus 32 may be used for these patients.